With that, I'll introduce the next speaker, who is Grant Schulert, who is an assistant professor here, and his research focuses on MAS and SJIA. And Grant will tell you about diagnosing and treating SJIA.
Thank you, Rashmi, and good morning, everybody. And I would also like to echo what she said and thanking you all for picking the nicest Saturday we've had in Cincinnati all year to come and spend the day inside with us. I hope that what we can offer you is going to be valuable, because we know this is valuable for us, not just in the research samples that she was talking about, but for us to see you. So often we get focused on the patient that's right in front of us, and we can't step back and see the whole community of you. So to meet you, to hear your stories, and to hear what are the needs of patients with systemic JIA, because that really powers the work that we do. I'm going to talk a little bit just broadly about systemic JIA, how we think about it and how we diagnose it. Dr. Lovell sort of touched on this, and in fact, a couple of these slides I stole from him, so they may be a bit familiar. And then a little bit on treatment of systemic JIA, what our standard approach is, and then some of the next wave of things that are coming down the pike, which hopefully this afternoon we'll have more time to sort of talk about and consider. So systemic JIA has had many names over the years. It was actually first called Still's disease, named after the British physician who first described this, Sir George Frederic Stills, who was actually Britain's first professor of medicine, and described many other childhood disorders, including what we now know as ADHD. But he described a group of patients at the end of the 19th century with what we now know as systemic JIA. We've moved away from calling things by the names of the very smart but the old white men who described them first, and it was then called systemic onset juvenile chronic arthritis, systemic onset juvenile rheumatoid arthritis, and now under our current classification, systemic JIA. Of course, once you turn 16, we call this adult onset Still's disease, and there is some consideration that maybe we should rename it, because some of you, as you know, have not had arthritis. And so by saying that this is a kind of arthritis minimizes some of the other features of the disease as well. But this is considered one of the types of chronic childhood arthritis. And the official diagnostic or classification, I should say, criteria of this is having arthritis for at least 6 weeks before the age of 16. As I said, after you turn 16, we call this adult Still's disease. But not just arthritis, this arthritis plus fevers, which are classically every day, lasting for a period of at least a couple of weeks. And then some of the other systemic features of the disease, where it gets the name of systemic, this classic rash, enlarged lymph nodes, inflammation of the liver and the spleen, sometimes fluid around the lungs and the heart. I put an asterisk next to the 6 weeks because that's the sort of official classification, but we don't want people to have arthritis for 6 weeks, so we certainly don't let them stick around for 6 weeks or before we say, aha, this is systemic JIA. So this isn't really in practice definition, this is more sort of how we classify things. And as Dr. Lovell said, that this is in a family of other chronic childhood arthritis. And it has differences in a lot of key features of the disease. Many of the other types of arthritis have a very strong female predominance. Systemic JIA really doesn't. It doesn't have some of these lab markers that we see in other types of childhood arthritis. There can sometimes be eye disease, but it's pretty rare compared to other types of juvenile arthritis. And it has these really classic high spiking fevers and rash. And a lot of times pediatricians, when they see somebody who has one of these other types, are confused because they don't have fevers and rashes and say, well, I heard JIA has fevers and rashes, but it doesn't always. And as I said, the arthritis is part of this, but it's not all of this, and not everybody has arthritis. So if you think about at disease onset, most children with systemic JIA have arthritis. Sometimes it can be many joints, often it can be a couple joints, sometimes it can be one joint, but in at least 1 in 10, there is no arthritis at the beginning. Some of those some of those children, if they were not treated, would develop it over the course of the next 6 to 12 months or so. But some probably would never develop arthritis, and we don't know why that is. Fever is really the thing that defines this from other types of arthritis. This is this classic fever graph where it spikes 1 to twice a day. I talked to several of you that I met yesterday. We talked about when the child first got sick and would often say, yeah, every day in the late afternoon or early evening, they would spike a fever. We'd give them medicine, they'd go to bed in the morning, they'd wake up, they'd have no fever, and then we'd repeat that cycle all over again. That's the classic fever of systemic JIA. Rashes. There's a kind of this classic rash. This picture actually in the middle was taken by one of our former fellows, Dr. Tournier, of a child with systemic JIA. This classic salmon-colored flat rash. The picture on the right, there's a rash that appears at sites of contact with clothes or when you itch or scratch it, called the Kobler's phenomenon, which is also one of the other classic rashes of systemic JIA. Lab tests, we always say this when I meet patients at the beginning who we think they might be systemic JIA. There's not one test that says this is systemic JIA or says this is not systemic JIA, which is one of the most challenging things about diagnosing this disease. But there's patterns that we think that we see in the blood work that makes us more or less suspicious for systemic JIA. In the blood counts, again, at the beginning, most but not all patients have some degree of anemia. It can just be a little bit. It can be very severe anemia. Often they have very high white counts, particularly the neutrophil count. Often they have high platelet counts, sometimes very high, except during macrophage activation syndrome or during early MAS. And that actually, those patients make us scared, is when we see somebody who we're convinced has systemic JIA, but their platelet count is not high. We worry, are they in the early stages of MAS? And Dr. Grom's going to talk more about MAS in a few moments. There's often very high markers of inflammation, and these are all very nonspecific. They just tell us the immune system's being turned on. They don't tell us, is that because of an infection? Is that because of leukemia? Is that because of another autoimmune disease or autoinflammatory disease? But markers like the CRP or the SED rate are usually high, not always, but almost always. The ferritin is something that's a little bit more systemic JIA specific. When that's high, particularly very high, that really kind of piques our suspicion that this could be systemic JIA. But in about a third of children with very classic systemic JIA, it's not high. In fact, it's never high. The other things that we think of as the rheumatology tests, or I should say maybe general pediatricians think of as the rheumatology tests, ANA, rheumatoid factor, those are almost always negative. In fact, under the strict classification, if it has a positive rheumatoid factor, it's not systemic JIA, it's something else. But as I said, there's no test that rules out this diagnosis, and there's no test that makes this diagnosis. And so when doctors call us, that they say, I have a child in my office, I'm worried they could have arthritis, what labs do you want? It's kind of a hard question to answer because we need to see the patient, because any combination of all these tests could go along with systemic JIA, which makes it a challenging disease to diagnose. So how do we treat systemic JIA? I kind of can think about these as sort of over the several eras of treatment. The pre-biologic era, which was before the time of myself and some of the younger doctors like Dr. Canna. Some of our more senior partners lived through this era, which was a very challenging era for doctors too, because they couldn't do a lot for their patients. Fortunately, most of your children are sort of beyond that, have been diagnosed in the more modern eras. Then there were steroids. There were lots of steroids, and there were more steroids. There were NSAIDs, aspirin, Indocin, which helped sometimes bring down some of the fevers and the inflammation, but not entirely. Steroids could often bring symptoms under control, but at the cost of a lot of side effects. Other medicines that worked well for other forms of arthritis, like methotrexate, were tried with not a lot of benefit. So before about the year 2000 or so, this attention. Hopefully not this portion. Before this, the outcomes in systemic JIA were quite bad. Many children ended up with very destructive joint disease. Many of them had growth failure because of steroids and inflammation. And many of them died from complications of the disease, particularly macrophage activation syndrome. Around 2000 was the introduction of the first biologic agents, the TNF inhibitors, and this I can sort of think of as the first era of biologics, of the TNFs. Medicines that we still see advertised. I joke that I know that I watch old people television when all I see is ads for arthritis medicines. But Enbrel, Humira, Remicade, which are still some of the biggest selling drugs of all medicines in the country, which worked wonders, were a real revolution for care for other forms of juvenile arthritis. But didn't do much for systemic JIA. And Dr. Canna is going to talk after me a little bit more about sort of some of the differences between systemic JIA and other forms of arthritis and why that may be. The sort of second biologic era is where we sort of branched beyond the TNFs to other pathways. And that's where we've had the real revolutions in care in systemic JIA over the last decade. And I think that we're on the cusp of a new biologic era as we move towards kinase inhibitors, potential oral medicines, and moving beyond blocking just IL-1 and IL-6, and trying to understand what are the best patients to use each of these medicines for. As I said, TNF inhibiting agents did not have a major impact on the outcome of systemic JIA patients. And I'm going to leave the why unanswered question to Dr. Canna to explore a little bit more. But the short answer is that TNF plays a smaller role in systemic JIA, and some of these other parts of the immune system play a bigger role, particularly these things called IL-1 and IL-6. IL-1 is really at the center of this. It was known for a long time that that's one of the main drivers of fever. And since systemic JIA fever is the necessary criteria for us to think about systemic JIA, it's not too surprising that IL-1 is really central to that. It has other effects on other parts of the body that we see affected in systemic JIA. The liver, effects on the bone marrow and the ability to make all those cells that are often down in very active systemic JIA, as well as effects on the joints. And in its ability to drive IL-6. And so we now have several medications that block IL-1 that are in our arsenal for things to help kids with systemic JIA that are different in how they work precisely, but all affect essentially the same pathway. And these are anakinra, canakinumab, or rilonacept. Currently, only one of those, canakinumab, is FDA approved for systemic JIA, although almost all patients start on anakinra. Often that's insurance-driven, which is ironic considering it's not approved, that when you ask them to start an FDA-approved medication, they say you should try something that's not FDA-approved first, but that's a little tangent there. They're all thought to work fairly equivalently, although they have differences. Certainly, in some patients will respond to one, but not another. The effectiveness of them is quite good. I'm showing, this is a slide of data from the large canakinumab clinical trial, which I show not because of any superiority of canakinumab, but because it had the largest and best designed clinical trial, which is why it has FDA approval. But what they found was that even after a single dose of canakinumab, more than 80% of patients had at least some response, and a third of patients had complete remission of their disease after a single dose. And these were patients who'd often been sick for a while. They'd tried many medications and those other pre-biologic medications and not responded to them. But the other, anakinra, rilonacept, often have just as dramatic responses. Again, here, meeting some of you over the last day or so, people saying, he started anakinra, and by a week later, a child who had never walked was running. And so very dramatic responses in some patients, but not all. And then IL-6 being the other sort of key treatment target that we have right now for systemic JIA. IL-6 also really sits at the center of a lot of the problems and parts of the disease that we see in systemic JIA. IL-6 level really tracks fever very, very strongly. It comes up, and then, do you see my marker on the yes? And then fever really follows. It affects the joints. It really very dramatically affects growth. And there's a very nice study showing how much catch-up growth patients get once their inflammation is controlled with a medicine such as Tocilizumab. Very closely tracks other markers of inflammation. It affects bone health. It affects blood counts. Really at the center of a lot of the things we see in systemic JIA. So Tocilizumab is the other FDA-approved medication for systemic JIA. IV infusion. There's an injection form, which is not formally approved yet for systemic JIA. It was just approved for polyarticular JIA. And it also had very high response rates, even in children who didn't respond to IL-1 blockade. And this is again from the Tocilizumab clinical trial, showing that that more than two-thirds or so of patients had some response, and many had a very dramatic response to Tocilizumab. So what's our approach then? How do we think about which of these medicines to use and how to treat children with systemic JIA? There are treatment guidelines from our professional organization, the American College of Rheumatology. They are now somewhat dated. They're in the process of beginning to update them, and hopefully will include a lot of the new information we've gotten on the use of these biologic medications. There's also these consensus treatment plans from the organization CARRA, which many of you are familiar with, the Childhood Arthritis and Rheumatology Research Alliance, which is an organization consisting of most of the pediatric rheumatologists in North America. This was developed now almost 10 years ago through a consensus approach to talk to the doctors of saying, how would you treat newly diagnosed systemic JIA? With a goal of standardizing these algorithms to facilitate comparative effectiveness research, to try to understand what's the best way to treat this without having to do a formal blinded clinical trial. We were talking actually early this morning about the limitations of this because patients are not algorithms, and very rarely are we able to stick to the exact pathway of what this has, because none of the two of your children have the same story, and the complications they've had and how they've responded to the medications and how they've needed to use other medications. It's all very different, but I think it provides a roadmap for how we think this could happen. So the pathways that CARRA had proposed now several years ago was using steroids alone, which was often how things were done in the pre-biologic era, and in some patients was all they needed and they would enter remission. Using methotrexate along with some steroids as needed, again a pre-biologic plan, and then these two biologic plans of using IL-1 blockade or Tocilizumab along with steroids as needed. A pilot study of these was conducted and was recently published and showed that most now patients were being treated with these biologic plans, probably almost 3/4 of them. And of the patients who started on these non-biologic plans, the steroid plan or the methotrexate plan, many of them ended up switching ultimately to using a biologic. Sort of, again, demonstrating the role of biologics that they now have in our treatment of systemic JIA. There's now, starting in 2016, CARRA started something called the FROST study to try to understand first-line treatment for systemic JIA. Their goal is to enroll 200 patients nationwide at the beginning of treatment to try to understand the differences between the consensus treatment plans. There's also a biosample collection arm to this, which is funded by the SJIAFoundation, the collection of the samples that is. What's interesting is that those treatment plans were designed 8 to 10 years ago. This pilot study was performed 5 to 7 years ago. And now in 2016, our current practice is the non-biologic plans have progressively fallen out of favor given the increasing safety data, effectiveness data, long-term safety data with the biologics. And currently almost every patient who is being started on treatment is starting on one of the biologic treatment plans. Almost none are being started on methotrexate or steroids alone because what we're finding is that they can't wean the steroids, and then they move to a biologic. So what's next? We kind of think of this as something old and something new. As we said, 2/3 or so of patients respond very nicely to IL-1 blockade, 2/3 of patients respond very well to IL-6 blockade. Together, probably 85 to 90% of patients respond very nicely to those. However, that leaves 10 to 15% of patients who don't respond well to either of those. So what can we do for those patients? Well, part one is looking backwards to say, are there old drugs that we already know, already have experience with, that could be helpful? A great example of that is the drug thalidomide, which has a very negative connotation when people hear it because it was first developed and given to women who were pregnant and had very terrible birth defects and teratogenicity. It was actually never FDA approved. It was used in Europe and licensed there. At the FDA, before it reached its approval, this birth defect data came out and they never approved it. However, it has very good anti-inflammatory properties. And as long as you're not a pregnant woman, it actually has very good safety properties. It's not as effective, I don't think, as IL-1 or IL-6 blockade, but there are patients who don't respond to those who get some benefit from a drug like thalidomide. But then there is the looking ahead, and as I said, we may be thinking of this as now the third era of biologics. There are certainly more medications in development that target these same IL-1 and IL-6 pathways. Other IL-6 agents as alternatives to Tocilizumab, which I suspect we'll see there are some patients who don't respond to Tocilizumab who do respond to other ones, as we have patients who don't respond to anakinra but do to canakinumab. Within IL-1, there's also excitement about using small molecule or oral drugs that can actually block what makes IL-1 in the first place instead of just blocking its effects. But then these other kinase inhibitors, so these JAK kinase inhibitors, tofacitinib, which is approved for rheumatoid arthritis under the name Xeljanz, which you've probably seen advertised. I do on my old people television shows. Actually, Dr. Canna just showed me that as of yesterday, I think, or this morning, another one, baricitinib, was just approved for rheumatoid arthritis. There's a phase 3 trial for JIA, including systemic JIA, in process for tofacitinib. IL-18, which Dr. Canna is going to talk a little bit more about, is another sort of key immune player, we think, in systemic JIA. There was a small trial of a medicine that blocks that in adult Still's disease, which, as I said, is basically systemic JIA kids who get diagnosed after they turn 16, and it showed some promising data, particularly in patients who don't respond to other treatments. And then there's a medication, particularly for MAS, that blocks interferon gamma, which we don't think is an important part of normal systemic JIA, typical systemic JIA without MAS, but really drives MAS. It's been shown to be helpful in children with genetic forms of MAS that we call HLH, and there's a trial that's now in progress to study that in macrophage activation syndrome. So there's a lot of basic science, I think, has now given us several very exciting things that we're on the cusp of either moving to trials or already in trial phase to hopefully give benefit for those 10 to 15% of kids who aren't helped by our current medications. So that's where things stand now. I know we're going to have a chance this afternoon to talk more in panels and roundtables and small groups. I don't know where we are as far as time, whether we should just move on or we have time. So if there's any questions right now, these are my two curious daughters at home who are currently at swim lessons. But I'd be happy to, if there's any questions right now. Otherwise, I'm around all day, so we'll be talking more. Rush me.
I just was wondering about the progress with stem cell transplants.
That's a great question. And so when we say the question was stem cell transplants. So stem cell transplants is something else that sort of a phrase that encompasses a lot of different things, just like biologics do. So there's a whole range of things. One of them is what we sort of also think of as a bone marrow transplant, sort of giving somebody a whole new immune system. So if we think sort of a range of aggressiveness, I suppose, from stem cells, that's on one end, giving somebody a whole new immune system. That's been done by our center. It's been done by centers across the country and also in Europe in patients with very treatment refractory JIA of all types, but particularly systemics. Bone marrow transplant is a rough road, and there's a lot of, there's a fair amount of kids who don't make it through that process. For those who can, it offers the chance of cure. or long-term durable remission in some. There's actually a very nice paper that described that came out recently, including a couple patients that Dr. Marsh, one of our bone marrow transplant colleagues here at Cincinnati, had transplanted. The ones who make it through transplant often do very well. About 20%, I recall, die in the transplant process. The next one is giving somebody their own stem cells back. Sort of an autologous one. So not necessarily knocking out their whole immune system and giving them a whole new immune system, but giving them these immature cells to hope to sort of reset the immune system. There was a lot of excitement for that. The experience of it in Europe, more than in the US, has been plus minus. And then there's this new exciting area of sort of mesenchymal stem cells, which basically growing in the lab some of either your own or sort of a donor stem cells that have the ability to sort of quiet and calm the immune system. There is data in animal models of arthritis, more autoimmune arthritis than more things like systemic JIA, that is very encouraging. There are trials for this that are starting in other diseases, and there's interest in starting this in systemic JIA. There's a lot of excitement about it. We don't entirely know how these work, but they do seem that they have some ability to sort of calm and quiet the immune system. The question is how, number one, how safe it is. Second, how long-lasting and durable that response is.
When my daughter was first diagnosed, her ANA was positive, and now it's negative. How does that work?
Mm-hmm. That's a great question. So ANA stands for something called the anti-nuclear antibody. So basically, your body making antibodies against yourself or the center parts of your own cells, the nucleus. Everybody has a few ANAs, right? Anti-nuclear antibodies. We draw a line when we do the blood test of saying this level is normal, and above this level is not normal. And so there's a threshold. So when we say it's negative, what we mean is it's below the level that we care about, or above the level we care about. They're very high in many autoimmune diseases, in most but not all kids with other forms of JIA, many adults with rheumatoid arthritis, most adults with, or adults and children with lupus. They can also be increased for a little while in infections or in other times of inflammation, such as active systemic JIA. So sometimes those will go up, especially to sort of a low to medium level, and then will come back down later. As I said, that it's not typically sort of persistently or always positive in kids with systemic JIA, but it certainly can be. And we don't know what the significance is. In other forms of JIA, we know that that's a risk factor for eye inflammation and the uveitis. I don't know whether that would be the same case in systemic JIA. I don't know if anyone's ever looked at that.
You talk about being genetically predisposed to the mass. We've never been recommended to have any genetic testing. Is that something that would be worthy of doing to further define treatment, or?
That's also a great question. So a couple reasonably large for systemic JIA, right? I talk to people who study adult RA, and they talk about hundreds of thousands of patients, and I talk about a study with 40 patients as a large study. Relatively large studies have shown, one by us, one by the Italians, one by the Dutch, that have shown about a third of kids who have MAS in systemic JIA have some genetic changes that we can find, which is more than we see in kids with systemic JIA who don't have MAS. What has never been looked at is whether that actually can predict future MAS. And that would be then when we would say this is valuable, right? We should test for it. That we don't know. I suspect it probably is. There's one of our other collaborators and colleagues, Dr. Randy Crone at Birmingham, Alabama, is starting a trial of treating MAS with high doses of anakinra. And he is then checking genotyping, getting genetics on all of those kids who are in his ICU who have something that looks like MAS, whether it's caused by infection, by systemic JIA, by lupus, by malignancy, by whatever, and checking to see whether they have these these genetic changes too. I think that would be really interesting to look at in the FROST study. If that enrollment picks up and we get a good cohort, I want to propose to check that to see if that predicts in the future whether those kids get MAS. Because then we would answer that question and say, yes, this is valuable, we should do this on everybody, or no, this isn't valuable. There are other ways to do this that don't require a genetic test.
One last quick question. I think it's time for the next one.
Perfect.